Hello, ladies and gentlemen.
I feel very privileged to present my lecture online for IDS event. So my topic is clear orthopedic approaches of S8 in correcting the severe jaw discrepancies. This is my orthodontic team in Taikang Bible Dental Group, and my team has been working with Smartee Group for a couple of years, having some innovative work resulting in a series of new products. We call it the GS series. What we talk about today is one part of GS series, S8. Now, the lecture overview includes classification of malocclusions with facial prognathism and the physiological deviation of the mandible, pathological deviation of the mandible. All puts the emphasis on the Smartee S8 SGTB. So first of all, take a look at the classification of the malocclusions with specifically facial prognathism. Now, angle classification has been very commonplace in ortho clinic. We do recognize that there are lots of shortcomings and pitfalls in this classic classification, especially in China, where the Oriental population is dominant, and we do have a huge difference between the Western countries, the Western or Caucasian population and the Oriental population in terms of the nature of the malocclusion, the structure of the jaws, and the severity of the malocclusions. So we do need to have our own classification system. Now, today, due to the time constraints, we talk about only the malocclusions with facial prognathism. Now, if the patients with the facial prognathism come to your office, first of all, you need to have assessment of the facial profile other than the intraoral dentition. The first step we need to do, I emphasize again, the facial assessment. Now, if the patient comes to your office like this, the facial profile is quite protruding and the lips are quite soft and thick. Mouth breathing evidence is quite clear. Intraorally, we could see the alveolar bone is quite thin and the morphology or apex are quite visible. The frontal teeth are quite proclined, and the relationship between the upper and the lower dentition is such that the molar is class 1 relationship, that the frontal teeth have very increased overjet, not very apparent deep overbite, and the curve speed is quite flat. Now, if we take a look at the ceph, the shape of the mandible is quite favorable. We call it very flat or rectangularly shaped, and the chin point is quite prominent. So this type of malocclusion with facial prognathism, we call it dental alveolar originated. This is very commonplace, and the treatment for this type of patients might not be very difficult. The second one, the facial profile is also very protruding and very prognathic. The chin prominence is quite compromised, it's going backward. And intraorally, the alveolar bone is very thick, very bulgy. There's no appearance of the morphological root apex. So the frontal teeth are very straight. There's no proclination of the frontal teeth. And the relationship between upper and the lower teeth are such that the molar relationship is class 1. The incuspation of the buccal segment is almost perfect. There's not too much crowding. The ceph inspection indicates that the shape of the mandibular body is not favorable. We call it triangle shape. So this type of malocclusion, we call it skeletally originates. They have a genetic heredity, and the treatment for this type of a patient would be quite difficult. This is very commonplace also in the clinic. We have to be cautious about this category of the patient because not only the difficult rate of the treatment, but also most of this category of patients are young patients. They have a high demanding, they have a very high expectation of treatment outcome, and usually this type of a patient will be resulting to the concerted efforts between ortho and orthognathic teams. The third one is the one that are quite different from the previous two. We take a look at the facial profile. It's quite similar to the previous two types. what making the difference is the intraoral situation. Take a look. The alveolar bone structure is quite similar to the first one, the dental alveolar originated one, and the upper dentition is quite similar as well, the proclination of the upper frontal teeth. And what difference between this one and the first one is that the molar relationship class 2, okay, it's cusp to cusp all the way to the buccal segment, and we have an increased overjet together with increased overbite and a deep curve speed. And the mandibular morphology is quite similar to the first one. It's quite favorable. We call it, again, flat and rectangularly shaped. Okay. So this category of the patient we call mandibular positioning originates, indicating that there's some positional factor of the mandible forming this type of malocclusion. And the fourth one, we again have a quite similar appearance of a facial profile. Intraorally, the alveolar bone structure is quite similar to the second one. It's skeletally originated, it's very stubborn, and the alveolar bone is very bulgy, and especially the frontal teeth is quite straight, and the teeth in the buccal segment is palatally reclined. And the relationship between the upper and the lower one is quite similar to the third one. We have a class 2 molar relationship, we have a deep curve speed, deep overjet, and deep overbite. And the mandibular morphology is quite favorable, quite similar to the first and the third category. So this specific category of the patient we call it combined subtype 1. This is a combination between the second one, the upper skeletal nature, together with mandibular retrusion. Right? So we call it subtype 1, and the front teeth is quite straight. And then we have a final one. The facial profile is quite acceptable. There's no too apparent protrusion of the lower 1/3 of the dimension of the vertical or sagittal dimension. It's quite acceptable. And then intraorally, the alveolar bone structure is quite similar to the second and the fourth one. It's skeletally originated, and then the relationship between the upper and lower teeth are also manifested by the class 2 molar relationship, and the cusp to cusp interdigitation is quite similar to the third and the fourth one. What makes it different from the fourth one, the inclination of the frontal teeth is reclined, very obviously. And we do have an increased overbite and deep curve speed. The increased overjet has been hidden by the situation of the reclined upper frontal teeth. Right? So this category, we call it combined subtype 2. The combination again between the skeletally originated maxilla and the retrusion of the mandible. So we have a summary of the classification. The first two is the dental alveolar and skeletally originated. There's no elements of mandibular deviation or mandibular backward translation. The later three are all having a common characteristics about the mandibular backward translation. The maxilla is quite different. The first one, the mandibular positioning originated type is very dental alveolar nature, but the subtype 1, subtype 2, they are all, the maxilla have the skeletally originated nature. Okay? So this is the classifications for the malocclusions specifically with facial prognathism. Now, the consequences of the mandibular physiological deviation to sagittal dimension is very simple sentence, creating 3 depths in occlusion: deep overjet, deep overbite, and deep curve speed. As long as the mandible is protruding, the final consequence always will be the 3 perspectives manifested in the frontal teeth, or the relation between the upper and the lower dentition: deep overjet, front teeth; deep overbite, front teeth; deep curve speed, this buccal segment between upper and the lower dentitions. Are there any modalities that we could restore the deviated or displacement of the mandible? In this lecture is that we correct or we treat the orthodontic patients in such a philosophy that we correct the jaw discrepancy first before we correcting the individual teeth or in the constipation restoration. Okay? That's a very important philosophy. We cannot overemphasize this importance of this philosophy because we do have lots of failures, not very acceptable outcomes of treatment because we always having the teeth correction first, and then it will be very hard if the malocclusion having some mandibular positional factor. You have a teeth-to-teeth lodgement. It's very hard to achieve it. Now, theoretically, we have lots of information about the classification, about the etiology of the mandibular malposition. What is called SGDB and bonded SGDB? Our team has been working on the innovative work about the SGDB for more than 20 years. First of all, in the very first stage, I think it's like 20 years ago or 50 years ago, without having too much clear orthodontic advent or development, we have the acrylic form of the SGDB. Look at this patient, a young boy, 24 years of age, so complains of retreat lips or retreat chin or crooked teeth, everything. But look at the facial profile, it's very prognathic, the lips is incompetent, and the chin prominence is not very bad, but it's quite acceptable. And then the intraorally, we can see very typical scenario of the three depths: deep overjet, increased overbite, and deep curve speed. We took a look at the molar relationship again is class 2. I have to emphasize the relationship between the phenomena. Malocclusion class 2, sort of the class 2 molar relationship, it will be always coupled with increased overjet, overbite, deep curve speed. The main reason behind this is the mandibular backward translation. So this intraoral manifestation indicates the diagnosis. Take a look at the OPG. OPG tells us everything: the periodontal, the jaw structure, and the condylar shape. The length of condyles in two sides are not long enough. The physical contour of the condyle, especially the right side, is not very normal. And then everything, deep curve speed, we could see the lower dentition. The mandibular body morphology is quite favorable, it's flat and quite increased overjet, and then overbite. Together with the facial profile analysis, we could reach a diagnosis of malocclusion with facial prognathism and a combined subtype 1. So in this patient, the malocclusion has skeletal element indicating difficult in treating this kind of a patient. What we have is the bond SGDB. I think it's a revolutionary change of the typical Clark twin block. The upper one is bond fixed, the permanently fixed to the upper dentition together with a expansion mechanism, and then the lower one is removable, but the clasps in the molar and the first premolar make the retention quite reliable. When the patient bite together, what we could see that the relationship with front teeth has been changed quite dramatically. The increased overjet has been corrected. The increased overbite has been corrected. The molar relationship is converted from class 2 to class 1. Of course, if we have this outcome, we have to let patient wear this bond SGDB for at least 10 months. Okay. So with the passage of time, we have a partial bonding with partial placement of fixed appliance in the front teeth. So the orthopedic treatment is merging with the orthodontic treatment in such phase. No longer a traditional two-phase treatment. At the same time, with orthopedic mandibular advancement, we do have some work in the front teeth to align, to retract partially of the front teeth. So two phases being not totally merged together, but in overlapping partially. With the expansion of the maxilla or the decomposition of the buccal segment, the space is quite adequately corrected for alignment of front teeth. And then with the removal of the SGDB mechanism, what we have is a very solid, firm change of the front teeth. The front teeth have a very shallow overjet overbite. If you manipulate the lower jaw backward, it cannot be moved totally. But what left over is open bite in the buccal segment. This open bite in the buccal segment is not created by the SGDB therapy. It's already there because of the deep curve speed. If we have a patient with deep curve speed, with the normal malocclusion, the curve speed is hidden. The placement of the SGDB occlusal plate and together with the lower part. After that, what we have is to flatten the curved B together with the retraction of the front teeth backward further, and we end up with a very beautiful occlusion, not only the front teeth but also in the buccal segment. The class 2 molar relationship has been converted into class 1, and the deep overjet, increased overbite, everything, and the deep curved B has been corrected in a very acceptable and very beautiful way. For this kind of a patient, if you have a very clear diagnosis about the etiology of the malocclusion, you will not exhaust or extract the teeth. It's not like we have an increased overjet, we have to extract the teeth. If the increased overjet is caused mostly by the mandibular backward translation, we do not extract the teeth. We move the mandible forward to have a jaw discrepancy correction before we do the intercuspation restoration of the upper and the lower dentition. So the facial profile is also improved. In terms of aesthetics, it's quite a big change. We always take original OPG, and the 6th month or 7th month into treatment, we have another one and the final one OPG. Although it's not accurate enough, but it do have some information about the remodeling of the condyle. Take a look at the middle one. In the left side, you can see that based on the original contour of the condyle cortical bone outline, you have a new cortical outline on the top of the original condylar outline. Because of the new bone formation, with the time passage, it will be merging into the original bone. It's OPG evidence of the condylar remodeling, which is quite important for the mandibular repositioning. What S8 SGDB? This is a brand new product produced by my team and the Smartee clear orthodontics team. We have a bonded SGDB, and now we have a clear version of SGDB. We call it S8 SGTB. The physical form of the S8 SGTB is we have a base of a clear aligner, and on the top of the base we have a 2 occlusal splint in the upper one, together with the latch mechanism in the lower one. Physically, it's quite similar to the bonded SGTB, but it's totally clear. It's the universal form of the clear aligner version of SGTB. If the SGTB in place, the mandible has been forward placed, and the upper front teeth being opened, the overbite has been corrected, the deeper curved B related space in the buccal segment has been filled up with the mechanism of the clear S8, occlusal splint, together with the lower counterpart. Now, advantages of Smartee S8 SGTB comparing with the bond, the traditional one, wow, lots of advantages. But most promising advantage of S8 SGTB is that repositioning the mandible and correcting the individual teeth simultaneously. We remember that the first case indicating that we have a bond SGTB and we have braces on the front teeth, and the lower teeth is the removable one. Only after the removal of the mechanism could we start the alignment or curved B flattening in the lower dentition. We cannot do other way around. But now, with the clear version with SGTB, we do it totally simultaneously. So the phase 1 and the phase 2 are totally merged together. They're starting together from day 1. So this is most promising advantages of the S8 SGTB. Now take a look at the real case. S8 SGTB is combined subtype 1 is a young adult. Okay, with the morphological analysis of the mandible, it's very favorable, and we see the prominence of the chin is quite good. The deep overbite is evident in the South. 31 young lady. Intraoral, again, is quite similar to the one that we showcased previously with bonded SGDB. We have a 3 depth, deep overjet, deep overbite, deep curved B. The molar relationship are all bilaterally all class 2, indicating the positional translation backward. So how could we do that? Do we extract teeth? No. Do we put the braces on again? No. Do we have a routine clear aligner to distalize the buccal segment to intrude the front teeth, struggling in the teeth lodgement? No, that's not the right way to do that, because with teeth to teeth struggling, outcome is only the damage to the teeth. So with this kind of patient with positional element, what we do before we think about the teeth intercuspation, we think about the jaw discrepancy correction first. The clinical procedure for the S8 SGTB, we have two stages. Stage 1 is having the emphasis on the orthopedic effects. We advance the jaw first, the lower jaw forward. At the same time, don't waste any single minute. We're doing some correction of the malpositioned teeth. Correction of the jaw discrepancy and the correction of the malpositioned teeth are taking place at the same time, escalating the efficacy of the treatment very significantly. This is the S8 in place. It's quite similar to the bonded one, but what the difference is that we have attachment, we have the clear aligner base, we have lots of specifically designed procedures merging into the clear aligners, including the jaw advancement, including the individual teeth correction, including the crowding relief, the intrusion of the lower incisors, the gradual thinning of the occlusal plate, all these stuff, and including even the buccal segment distalization. With the accomplishment of the stage 1, what we have is only a limited open space. The buccal segment is much smaller than the bonded one. Why? Because with the bonded one, during the phase 1, during the orthopedic stage, there's no way that we can manage the flattening of the curve speed. With the removal of the orthopedic mechanism, we only have a very huge space in the buccal segment. This is one of the shortcomings of the bonded SGTB. But with the clear version of the SGTB, there's no longer having such a dilemma. When we finish the first stage, what we have is the beautiful correction of the front teeth relationship that with very limited open space in the buccal segment, because we did have lots of work in the first stage, including the intrusion of the lower incisors, including the buccal segment flattening. So all the stuff putting together end up with a quite beautiful outcome. And the second stage is much simple because we are just doing some intercuspation digitation lodgement and some detailing of the midline or overjet, overbite or something. That's going to be the stage 2 is really a stage that we do not have heavy task as the first stage. So take a look. This is the almost the finish. What we change is quite similar to the bonded one. There's no compromise at all, but efficacy of the treatment is much higher, and the time the treatment course is much shorter. I think it's 1/3 shorter than the routine fixed appliances. We have a correction for overjet, overbites in the front teeth. We have a beautiful intercuspation in the buccal segment. We have a conversion of the molar relationship from class 2 to class 1. And we have everything. There's no any sacrifice of teeth, no extraction of the teeth, except for the terminal wisdom teeth. The patient will be happy with that, and more importantly, that we doing this modality of treatment based on the etiology of the malocclusion, other than a clinical manifestation, the superficial manifestation of the malocclusion. Look at the OPG again. If you look quite closely at about the condyle, both sides of the condylar, bone formation is quite evident. We call it SGTB condyle. They're always favorable for the condyle. And the facial change is quite dramatic. This is the one presentation of the S8 SGTB. We have a summary of the S8 SGTB indication. What's S8 indication? Physiological deviation of the mandible and 3 depth in occlusion. Now, if you feel that the classification is complicated in the first place, then just memorize very simply about the indications of the S8 SGTB, as long as the dentitional manifestation is 3 depths in occlusion: increased overjet, increased overbite, deepened curve speed.